Ji, Bismillahirrahmanirrahim. Those who are here for TAVI workshop, please be seated. Please come forward. Have your seats, please. Those who are here for TAVI workshop, please. Ji, please, those who are for TAVI workshop, please. There are few people waiting outside. उनको भी कह दें अगर आ जाएं तो. So we all understand that these are extensive procedures, metal valve procedure or structural heart disease, or they are usually whole day or a few days workshops, and we are trying to compress things in 90 minutes. So we are compelled to be faster, but we have got senior faculty with us, Dr. Tariq Ashraf, Dr. Irfan. They are all available throughout the day. So, and we will be requesting the administrations that if they can keep this Mentis and the instruments there. So after completing today's sessions, I will ask them, you can come back and practice on these Mentis and things. So it will be better. You can come in smaller groups, and because this TAVI, as I'll be discussing, and you will understand that we did a workshop. Probably took us a whole day for this TAVI workshop because we were discussing each and every step one by one. What are the precautions? What may be the complications? So what are the things you need to be careful in each step? So it's a whole extensive thing, but I think that we will be covering. So यार एक क्योंकि इसके लिए हमारे पास वो भी है, मैं वो सामान भी मंगवा लूँ ज़रा, जब तक हम ये पूरा कर रहे हैं उस वक्त तक वो आ जाए. Because what our thing is that we have got we will be dividing this one into 3 sessions. First thing is that we will be discussing theory step by step. That's what I call it, a software, that we understand the things theoretically and see the things theoretically. Then, like again, as we have got the table at the back, so we'll be bringing in the instruments, the TAVI instrument, the delivery system, how does it look like, how do you feel it, and the original valve, how does it look like. So you will be able to see the valve, you will be able to see the instrument, and then finally you will be practicing on this Mentis. This Mentis has got this whole system so that you can take the valve and how does it feel like and how to deploy. So this is the whole workshop is like this. And अस्सलाम वालेकुम सर. वो उसका ये जो तावी के जो था वैल्व और डिलीवरी वाला, वो अहमर ने कहा था कि मेरे पास है, वो लेके नहीं आया अभी तक, फ़ोन भी नहीं उठा रहे. मैं शुरू कर रहा हूँ यहाँ पे, तो अगर वो पीछे ला के रख दें. Okay, so let's start. Bismillahirrahmanirrahim. So basically, again, I will be not looking at Dr. Mujib and Dr. other people who are senior, one even senior to me. I'll be focusing mainly on people and considering that you don't know anything about TAVI, so that we will not skip anything. And we will start with very basic from 0 point, what is TAVI and why is TAVI and what are the things, and then we will build up the things so that we understand everything and we will not consider that we are discussing with consultants. So that we will not miss anything. So what is the objective is that what is TAVI, and then why we should do TAVI, and TAVI workup, what are the things which we need to do, and then step by step TAVI. So I try to be quick on these first three things, because our main aim is to do TAVI step by step. What are the steps, how to deploy, what are the views, how to cross the valve. So our workshop is not focusing on theory. Our workshop is basically for the technical things, how to hold things, how to proceed forward. And then troubleshooting, Dr. Tahir Saghir will be with us inshallah for the complication sessions, that what are the complications we can anticipate and how to handle those things. Because it's not like this that you should not have complication, but you will have complications, but how to handle them, you should be prepared before this. And then handle your tools. So I think that they have brought the valve in and they are going to bring the delivery, so that we will divide you in two, and then one portion will go to that portion, one of group, and then we will shuffle. Okay, so and then perform TAVI on this Mentis. So what TAVI is, we all know the patient with severe aortic valve disease, we have got this new thing available, that this is a replacement of aortic valve without removing old damaged valve. In the new valve wedges and replaces the valve into aortic valve place, and this is called TAVI or TAVA. So how does it do? Basically, what we do is that you have usually, most of the time, you puncture the femoral artery and you take the wire in, and then you cross this aortic valve retrogradely, and then your wire is resting on this wire. Your valve rails, as we are all interventional cardiologists and we all know about this, that the valve rails over it, and then when the valve comes to this position, you release the valve. And this valve is basically mounted inside of a metallic frame, and that metallic frame, when it opens like a stent, it will crush and displace the damaged valve along with the valves. And inside this valve, you will see the original valve there. Inside that valve, there is a tissue valve, and that tissues will start working immediately. We will see all of those things. This is just theory, and we will be clear inshallah at the end of this whole workshop. You will be clear with all of the steps. So there are two basic types of valves. There are different companies making this one, but there are two basic types. One is the Sapien or a balloon mounted valve. This valve is mounted over a balloon, and it's very similar to a stent, but the difference is that it has got this tissue valve inside. So when you take this stent and place it over the damaged valve and inflate the balloon, the valve will open, it will crush the remaining thing, the damaged valve, and the new valve will immediately start working. And the other one, which is more frequently available in Pakistan and more frequently used throughout the world, is self-expandable TAVI valve. So there are two types, balloon expandable and self-expandable. How does this self-expandable works? Basically, it's a compressed spring. इट इज़ अ कंप्रेस स्प्रिंग. एक स्प्रिंग है जिसको जैसे ही आप जो हैं वो रिलीज़ करते हैं, वो फ़ौरन अपनी जगह पे वापस बाहर आ जाता है. उस स्प्रिंग को कंप्रेस करके यू हैव केप्ट इनसाइड दिस शीट. और जो लोग पेरिफेरल करते हैं, दे आर वेरी फेमिलियर विद सेल्फ एक्सपेंडेबल वाल्व्स, दैट यू जस्ट व्हाट यू नीड टू डू, इट्स अ स्प्रिंग विच इज टेंडिंग टू एक्सपेंड, उसकी कोशिश है कि बस किस तरह खुलूँ, उसको आप यू हैव कंप्रेस एंड प्लेस इन अ शीट. एंड व्हेन यू come to this aortic valve position, you position your valve and then you hold the valve and you remove your sheet. So once you remove your sheet, the valve start expanding, and as soon as it will expand, it will automatically replace the damaged valve. We are not here to discuss many things, many indications, many other things, but so this frame, this metallic frame is a unique frame. It's not simple a metallic frame. It has got, this is made up of nitinol, and this has got the capability that when it warms up, it will expand further. It will definitely not expand unlimitedly. It will expand to certain limits, to a maximum point. But the most important thing is that जब आप इस valve, when you prepare this valve, आपके पास ट्रे में बाकायदा बर्फ़ पड़ी होती है. आप नॉर्मल सेलाइन को बर्फ़ में जमाते हैं और उस बर्फ़ के गोले आपके पास जो हैं वो ट्रे में पड़े होते हैं. आप सब उर्दू समझते हैं ना? उसके गोले बाकायदा जो हैं ट्रे में पड़े होते हैं और उसके ऊपर जो है उसमें आप valve डालते हैं so that it shrinks. When it shrinks, you will compress it and load it on the sheet. So when it comes directly into the blood is warm. So it will start expanding gradually. Immediately, you may have some aortic regurgitation, but usually this regurgitation resolves after 15-20 minutes in even up to 72 hours. We will be seeing these things further. So, and again, it has got the different part of the valves have got different strengths. The valve is basically going to hold on this part at the annulus. This is the main part which is going to hold on the annulus. And inside this one, this is the tissue. Other part, this valve is not going to hold at this part. This is just to keep itself oriented into the ascending aorta. ये ऊपर वाला part का ये even if it is not touching the aorta, it doesn't matter. The valve is going to control at the annulus, and this is the part which is going to be measured, and this is the part you want to be in contact with the valve. Okay, so is it really for us? We already know that our surgical capabilities, we are comparatively a younger generation, younger nation, and we know that we have got many high-risk patients who are not being treated with surgery. So the expansion, the TAVI is expanding. And there are a few things which we usually see. Do we need it? Yes, we really need it. Initially, when this thing came in, people thought that this is not for us, this is too expensive. But now the cost issues are being resolved, and there are many things which we are doing. So I think that there are no more issues with it. Do we really need it? Yes. We have got a lot of patients with severe AS, and their quality of life will be improved if we go for this valve. Can we afford it? Yes, definitely. Affordability issues are being solved as the new companies are coming in. It was much more expensive, but the things are being solved. The authorities are looking at it, and inshallah we'll be getting it in lower prices as the new companies. Does it really work? Definitely, be at an ICVD, we have done more than 100 cases, and we have got very good results. People with have got good quality of life. The important thing is the good patient selection. So nowadays, we are selecting especially those patients who are really high risk, patients with EF 20%, and most of the patients we are doing without anesthesia. So they are being done in conscious sedations, most of the patients. So as the experience, the team experience, the anesthetist experience is growing in, the complications are reducing and things are getting better. Is it jais? This was the question which I asked myself, because this is the thing we need to understand. This is a porcine valve. इसलिए सबसे पहले when it came in, I decided that I will withdraw from it. I will not go for a porcine tissue. लेकिन वी हैव डिस्कस्ड विद जो बाकायदा तौर पे जो इस लाइन के उलमा हैं, and it's being done at Medina and other at KSA and other areas, and it's not my field, another field, but this is the question which most of us will have in our mind, that whether we can go for it. Yes, we have discussed with ulama, they say yes, it's okay, you can go for it. And what if we don't learn TAVI? Now, I think this was a question in the beginning, but I think that with the growing number of cases, with the growing number of indications, and I will tell you further, because I just want to bring interest into this whole workshop. You will see what are they are planning to. Let's see. Initially, international updates. Initially, the TAVI was the changing indications. Initially, the TAVI was considered for high-risk patients, and the support was from many of the trials like TAVI trial, and then they started doing it on moderate risk patients. And on moderate risk patient, they found out that the patient who has got moderate risk, they still get benefit. So the TAVI, it was few years back, not now, the TAVI was approved for moderate risk patients. And then after the Notion trial, they found out that even the low risk patients they get benefit from TAVI. So just today somebody asked me what are the indications for TAVI. I told them clearly at NICVD, what we do, we say if surgeon is not agreeing for surgery, the only limitation is that patient should be older age group. Why so? Because this is a tissue valve. And the tissue valve's life expectancy, overall expectancy is 5 to 10 years. So अगर आप 20 साल के एक आदमी में tissue valve लगाते हैं, it's not jais. It's not worth it. And another thing is कि किसी ने मुझसे आज ही ये कहा कि अच्छा फिर बाद में इसको सर्जरी कराना पड़ेगी. This metallic whole frame will adhere to LVOT and ascending aorta. ये नहीं हो सकेगा कि आप जो कह रहे हैं कि जी 25 साल के लोग का तावी हो जाए, तो फिर उसको बाद में तावी पे तावी कराना होगा. Valve and valve will be the solution. He will not be able to go for aortic valve replacement. आप किसी को आज टिश्यू वाल्व सर्जिकली लगा देते हैं, बाद में आप मेटालिक वाल्व लगा सकते हैं, लेकिन दिस मेटालिक ह्यूज फ्रेम इज गोइंग टू एडहेयर and cause fibrosis of LVOT and ascending aorta. And after 10 years, when you say this valve has given up, the only solution will be valve in valve. That's why we always insist that please don't send young patients for TAVI, because after 5 years ये आपके पीछे फिर रहा होगा कि अब मेरा कुछ करो. We'll see. Okay. So and the high-risk patients, I'll be quick. Treatment of choice, class 1 recommendation, and these are the intermediate surgical risk. These are partner 2A, TAVI. They told us that you can go for intermediate. Low surgical risk patient, Notion trial, 300 patients, and finally they came out that even the SCS score was around 3. Usually we take more than 4 is intermediate risk and more than 8 is high risk. So they took patients of 3 score and they found out that TAVI is non-inferior to surgical AVR. So after this one, they started doing TAVI on low risk patient. And what are they heading for? Look at this. Asymptomatic severe AS. Asymptomatic severe AS को हम क्या करते हैं वैसे? कुछ नहीं करते. Medical management पे. What they are saying? Risk of sudden death, asymptomatic severe AS is 1 to 2%. And surgical risk is 5%. That's why you don't send these patients for surgery. But now they're saying TAVI risk is less than 1%. Lihaza, they are pushing things towards that in future, asymptomatic severe AS, which are being treated medically, but they are at risk of sudden death. They will ask you to put a valve, TAVI valve in it to prevent sudden death. Because TAVI risk will be lower than 1%. So this is the future. That's why we need to learn TAVI. We all interventional cardiologists, this is going to be the future of interventional cardiology. This is the way how things are going. So this is the time to prepare ourselves for it. Okay? So I think this brings up enough interest. So they started and they are looking for it. So I will skip this thing because you will see those things on the slide portion. Initially, the core valve was the valve which was covering. The covering was lower, and the shorter covering, it was self-expandable but could not be retrieved. Then the new Evolute R came in. Evolute R was retrievable. But they found out that when you place this valve, there is a lot of paravalvular leak from the lower side. So they increase another skirt outside this valve, which is Evolute R Pro. Evolute Pro, this is the third generation of the valve. So nowadays in Pakistan, we are doing with this Evolute R, but Evolute R Pro is also available in the world, and this has got additional skirt. This additional skirt is to prevent further paravalvular leak. Okay, I'll skip this one. Okay, and patient selection, echo, CT. The main message of TAVI is that everything is decided before procedure. Everything, every step. You will pre-dilate or not, you will post-dilate or not. Okay, you can change decision in between. The operators are there. But everything, what size of the valve, which axis, from where you will puncture, everything will be decided. So echo and CT is very important, and your initial workup is very important. We, the interventional cardiologists, are basically in habit of doing things on table. Even if we have seen the angiogram, we will see that, okay, I'll decide on table what size of stent I'm going to take. हम उसी वक्त decide कर लेंगे. You need to control your reflexes. Okay. So they say that there will be no break in between because we are a bit late of time. So those who want to have tea or biscuits, they can in between come, and there is a tea and biscuits there. So you can go and take the things and continue sitting here. Okay. So so that is the most important thing, that you decide you want to go from left femoral, right femoral, and we will be discussing the femoral part. Subclavian and transeptal is beyond our discussion for today because they have got different steps. But what we do is that you take a baseline image, you puncture the opposite side from which you don't want to take the device in, and you take a baseline image. In this baseline image, what you want to see is the tortuosity, and the most important thing is that from where you want to puncture. Important issue in this one is that definitely we know that this femoral head is the last marker. Femoral head is the last marker from femoral head. Upper boundary is the inguinal ligament. But people are different, and the bifurcations are different. And even some of the people, the inguinal ligament and the femoral may have dysplasia because we are having these old age people. So usually the last branch which we see from here is inferior epigastric artery. ये आपकी आखिरी boundary है, because this is the last vessel which arises above inguinal ligament. So you will never puncture above this artery. So your working territory is from this branch up to the bifurcation. ये आपका थाना है, इसके अंदर अंदर काम करना है. जो भी पंचर होना है फेमोरल आर्टरी का पंचर, वो इंफीरियर एपिगैस्ट्रिक आर्टरी एंड बाइफिकेशन, इन दोनों के बीच में कहीं होना चाहिए. अगर इससे ऊपर है, डेफिनेटली यू विल कॉज रीट्रोपेरिटोनियल ब्लीड. इससे नीचे है, इट विल बी डिफिकल्ट टू क्लोज, यू विल हैव चांसेस ऑफ फिस्टुला and many other problems. So this is the safe zone. So that's why you inject, identify the anatomy before procedure, and then you puncture from this one, and you always puncture under fluoroscopy. Before puncturing, you want to keep a safety wire there. Most of the complications of TAVI are peripheral complications. And peripheral complications, most common are perforation, and most common perforations are iliac. So most common are peripheral complication, most common is iliac. So what we do, you try to keep a safety wire here. So what we do, you see a pigtail here, and from pigtail a wire is going in, and this wire is going to be placed into the femoral artery. So that you will puncture femoral artery, do the procedure, but this wire is lying there, so that at any point you find any perforation, you can slide your covered stent over this wire and deploy it. So this is a safety wire which is placed from the opposite side femoral artery, and this wire is lying workless. You don't, most of the time you just pull it back after the procedure, but this may be life-saving for someone in 2 or 100 patients. So safety wire is placed, and this wire is crossing into femoral artery, and you keep it there, and you then puncture from the femoral artery and go up. Okay, next step is that in this procedure, most of the time, sometimes you may need rapid pacing. So you put a TPM lead. Again, I don't know what happens, but in TAVI, it is documented worldwide that you tend to perforate with the TPM lead. Probably वो वर्कर जो भी काम कर रहे होते हैं, मतलब एक आदमी सोने का काम कर रहा है, एक आदमी जब कसाई का काम कर रहा है तो उसका हाथ जो है ना वो तो I don't know what happens, but it around 10% of the perforations are RV perforation with the TPM lead. So that's what we tend to change our practice with the 5 French balloon tip TPM lead. So that may save a day for you. And next thing is you puncture, and then we can go sheetless. But what I just wanted to show you that this is usually a 18 French sheet. Sorry. So the 18 French sheet goes in, and usually we take it over an implanter stiff wire. This is not done. So when you puncture, you put a stiff wire, and then you take the 18 French sheet. And after this one, now you come to your working area. And in this one, first thing is we take a baseline image to identify the valve, the calcium, the LV, TPM lead, so that you have got this image at your background when you're working in. Most of the time, the crossing view is a coplanar view. What is a coplanar view? A coplanar view is that angiographically you want to have a view in which you can see this left cusp, right cusp, and non-coronary cusp in the same level. This view is important to know the depth of the valve, how deep you want to place a valve. Nowadays, there is another view which is called cusp overlap view. This cusp overlap view, in this view, you keep the left coronary cusp separate, and you overlap the non-coronary and the other cusp. So the two cusp overlap, and there are different utilities of these two, both of these two views. We may discuss it in detail, but this is something beyond the technical steps. But the important thing is that I tell you briefly. I think पेट में नहीं रुक रहा, because TAVI के अंदर जो एक issue है वो है chances of having a complete heart block. Your bundle of his is, or your main conducting system is crossing near to the non-coronary cusp. नॉन कॉर्नरी कस्प से जितना ज़्यादा आप डीप वाल्व को प्लेस करेंगे उतना ज़्यादा चांसेस होंगे पेशेंट के कंप्लीट हार्ट ब्लॉक में जाने के, बिकॉज द कंडक्ट सिस्टम इज समवेयर हियर. सो व्हाट यू डू that you place your valve in this cusp overlap view, because in this view the lowermost cusp is non-coronary cusp, and this is the your last limit. For beyond this one you will go into LVOT. So you place your valve in such a way that the valve lies here, doesn't go beyond this line. So this is a future preparation, a precaution. So when you deploy your valve in cusp overlap view, you reduce the chances of complete heart block and the need for permanent pacemaker. The more you go deep, the chances of having a permanent pacemaker will be higher. Okay, so this is what I was showing: coplanar view, aortic valve, all the valves coming in the same view. And when you have decided, then how to cross. एक तो है कि धक्का मार के जहाँ भी आप वायर से पुश करे जाएं, कभी ना कभी तो घुस ही जाएगा कहीं. एक टेक्निकली यू नीड टू नो कि व्हाट आई एम डूइंग एंड हाउ विल आई डू इट. सो व्हाट यू डू, यू टेक एन AL गाइडर, diagnostic catheter AL1. Most of the time 90%, 99% we cross with the AL diagnostic catheter, and you will take a straight tip, normal 3/5 straight tip wire, and what you will do, you will direct the cusp towards the left cusp and towards the left coronary, and then you go in and poke your valve. Poke, you will not be able to cross, then you will slightly pull. When you pull, the tip will be directing towards the center. Then you poke again. Then you pull further. You poke again. And at the same time, you will be rotating slightly clockwise. Slide clockwise and pull, check, slightly clockwise, pull, check, clockwise, pull and check with the wire. So it's most of the time a simple, peaking, gentle movements you will be easily able to cross if you are going technically. Otherwise you try to push. हो सकता है 15 मिनट हो सकता है कि पहली दफ़ा में चले जाए, लेकिन वो जैसे कुंडी साहब में कहते थे कि भाई साहब एक दफ़ा निकालो फिर डालो, फिर पता चलेगा कि आपने डाला है या खुद से किया है तो फिर पता चल जाएगा कि क्या है ये. तो इसलिए अगर निकल गया तो आप कहेंगे डी जी आई नो द टेक्निक, एक दफ़ा नहीं हुआ दोबारा भी मैं कर लूँगा, बिकॉज फर्स्ट टाइम आई डिड इट टेक्निकली and I can do it technically. So we need to know these steps, how to cross it. So the main thing is direct it towards the left cusp, poke your wire, pull, slightly rotate clock, poke again, pull, slightly rotate clockwise, poke your again. Because another important thing is, this is most of the time degenerative, sometimes mixed in our population. So you really don't know where the opening is. Most of the time the opening is eccentric. So most of the time what our experience is, it's somewhere here. आपको देखने में नज़र आ रहा था यहाँ से क्रॉस करेगा, क्रॉस यहाँ से करता है. तो most of the time the opening is eccentric. So whatever you are seeing is anatomic, fluoroscopically is two-dimensional. And whatever the central point you are seeing may not be the central point. Okay, after this one, your wire is crossed. So over this wire, you will take the pigtail in and bring the pigtail up to the apex. And after this apex, now the second hard wire goes in, which will be your working wire. This wire will go in and will be resting at the apex. Nowadays we have got dedicated TAVI wire, and what we are using is confida wire. इस वायर के अंदर इसका शेप ऑटोमेटिकली पिगटेल शेप बना हुआ होता है. इसका शेप ऑटोमेटिकली पिक्चर. Previously we were using Amplarzer super stiff wire and we used to shape that wire, but with the passage of time we had some incidents, we had some complications which Dr. Tahir Saghir will be discussing, so we changed our strategy and we have got this wire which is dedicated TAVI wire, which is 3-5 wire, super stiff wire, but a very soft distal portion. So there are no chances of LV perforation and damaging the valve. The next step is that fluoroscopically you check the valve if it is really, and आप उसमें देख भी लेंगे, वो अपनी दुकान लगा के बैठे हैं भी, तो उसमें कि this valve is loaded inside the system, ये properly loaded है, you see all the rims, there are no fractures, कोई compression नहीं है, क्योंकि अगर ये यहाँ पे सही से नज़र नहीं आ रहा, when it will expand asymmetrically और उस वक्त में valve सही से काम नहीं करेगा. तो फ्लोरोस्कोपिकली ये दिस इज़ आउटसाइड द बॉडी, ये हम फ्लोरो में चेक कर रहे हैं, लेकिन ये बॉडी में नहीं है, ये चेस्ट के ऊपर घुमा के इसको चेक कर रहे हैं. एंड नेक्स्ट थिंग इज द वाल्व डिलीवरी. द वाल्व स्लाइड्स over the wire, and then you take the valve in and then you place the valve. Conventionally, in these two systems, core valve or evolute, they have got some differences. That core valve, the distance between this marker and this marker is 4 millimeters. In new generation evolute, it's 6 millimeter. Traditionally, initially, because of the initial teaching, they were recommending to keep the valve 4 millimeter below annulus. But because, as we already discussed, because of the increasing incidence of permanent pacemakers, nowadays they recommend to deploy the valve in cusp overlap view and try to be as low as possible. And we try to deploy at 0 level. We try to deploy the valve even at this point. But in this case, you will see that we deployed around 4 to 6 millimeter below. So the other pigtail which is coming from the side will give you the imaging, checking. Then you start releasing. Now you will understand what I meant to say. This is a compressed valve. When you bring this sheet down, up, the system will go up, the valve will start expanding. The system is up. The system is up, the sheet is back, the valve has started expanding. And you place the valve, and you are checking your positioning. Previously with the core valve, once you release, you are gone. You can simply manually or forcefully pull or slightly push. But nowadays, because of the new systems, you can if you are not satisfied your position, you can retrieve it 2 to 3 times and then reposition yourself. And then once you are sure you have position, you release. Release the valve, take the whole delivery system back, and then check with the injection for any regurgitation. Again, as we discussed, that because of this core valve, you may have slight paravalvular leak. That's why initially people used to ask, जी उसमें तो AR mild था, तो we used to say जब भी तो कंपनी ने और नई वैरायटी बनाना शुरू की है, क्योंकि this is not the issue with NICVD or AFIC or other people. This is the worldwide issue, that this valve has got an issue of paravalvular leak. That's why they have changed their system and they are bringing in new things to prevent these complications. So there was mild paravalvular leak, but this leak also recovers after most of the time after 24 or 72 hours, because the valve will keep on expanding. This is something beyond this one. I'll skip parallax, how to remove and how to see these things. And When to predilate? When do we select to predilate? Usually it's not like coronaries because this valve has got a lot of radial forces. It will crush anything and expand to anything. But why we predilate? Sometimes we are confused about sizing. We don't know which size of the valve we want to take, or you have got dispute among the team. So the predilatation is done for how it's done, you will see. It's done for sizing, and if you have got a large calcified lump at the aortic valve, when you expand the balloon, the lump may shift towards the coronaries and block the coronaries. So you want to know it beforehand. So you balloon dilate and inject. When you inject the dye and with the inflated balloon, if you can see coronaries, you are sure that the valve is not going to obstruct coronaries. Or sometimes you have got low coronaries. Although low coronaries are considered contraindication, but we do some low coronary cases and we check it before the procedure for it by balloon, by predilatation or balloon injection test. Or if a person has got abnormal leaflet, we have got some patients who have got abnormally long leaflet. Again, we are afraid of that when the valve will displate the leaflet, it will go towards the coronary and obstruct the coronary. So you don't want to have it after deploying the valve. You want to see it, what will this leaflet behave after the procedure. So you do it with predilatation. So now you will understand how do we predilate. When you predilate, you inject. So in this one, even with the balloon fully inflated, you can see dye coming into the LV. So this balloon size or the equivalent stent size is not sufficient for this patient. You need to take a larger size stent, a larger size valve. So this is how this is used for sizing. Similarly, for like again in this one, this is something technical. When you balloon predilate or you balloon size, you go for rapid pacing, because when the balloon is inflated, an LV will try to push everything upwards. So in this one, you want to rapid pace so that the LV ejection fraction goes down and LV jo output goes down. So you pace usually at 200 per minute and bring down the blood pressure less than 60 systolic. And then only you inflate the balloon. If the pressures are higher than this one, there will be a lot of forces on the balloon that will try to push it forward. Okay, next. Valve sizing, this is the chart. Coronary protection, I think Dr. Tahir Sagil will discuss. And I think I am done with my things. Post dilatation, sometimes the valve does not expand. Okay. So post dilatation, sometimes again because of the LV calcification, sometimes because of fibrotic things, the valve may not expand and you see gradients still. So you can post dilate, but always whenever you dilate or pre-dilate or post dilate, this will be with rapid pacing. You will pace of a rate around 160 and bring down the pressures to less than 60 systolic. Most of the patient will tolerate, but definitely if patient has got 20% ejection fraction, 30%, we tend to avoid this step. And we try to go for direct pacing, because the patient, when he drops pressures of 20% EF, drops pressures to less than 60 systolic, when you stop rapid pacing, he may not come back. He not bring the pressures back. But most of the patient, they tolerate it. Okay, so complications. Valve malfunction. We had one patient, this is one of the known complications for this self-expandable valve. They found out that some of the patients, nowadays with the further research, they have found out that in some of the patients, the valve may develop some thrombus or valve dysfunction. We have got one patient, after around a year, the patient again got severe gradients. Patient was already not fit for the surgery. So the solution was we checked the gradients directly also and on echo basis, and then we put a valve in valve. That's what I was discussing with you guys. The next solution will be that you take the valve in, keep over the same valve and deploy it. Comparatively a easier procedure, but definitely a valve in valve will be the solution for these patients once this valve developed dysfunction. But out of our 120 round patients, this was the single case we had. Patient again came back after a year with the symptoms, shortness of breath, and when we did echo, we found that he has got severe stenosis again. Gradients have developed again. We did CT, we didn't found, but we came out with the world data. They said that this is a known complication with self-expandable valve, and they said that probably these leaflets develop some sort of thrombus. That's why later on, जब ये हमारा हुआ था उस वक्त में ये बात नहीं हुई थी, हमने तो अपनी गलती समझ के इसको खामोशी से आंखें बंद कर ली थी, पर दुनिया वालों की हुई तो हमने कहा अच्छा ये हम औरों से भी होता है, हमसे नहीं हुआ. They found out that some of the people they may develop thrombus, so they recommended that some of these patients they need rivaroxaban or anticoagulation for 3 months. And they found out that even in these patients, some of these patients who develop gradients, you give them a chance of anticoagulation if patient is not severely symptomatic, and they found out that this anticoagulation also resolved their symptoms. So that may be the thing. That came out that probably there is some sort of thrombus developing over this one, which dissolves with anticoagulation. Okay, so this is a complication and how to manage. So this is the thing which हमें उस वक्त पता ही नहीं था, हमने तो उस वक्त तौबा इस्तग़फ़ार की, हमने कहा ये हमसे कोई गलती हुई है. This was around in 2015. I am telling you because NICVD we are doing TAVI since 2015. So it was our initial second or third case. So he came back after 6 months or around a year. So in 2016 this was not in. This thing was not in. They used to say this is अब तो चलेगा 5 साल. हमारा वाले ने 6 महीने बाद ही आ गया. जी. Sorry? उस वक्त के अंदर जी हाँ, उस टाइम के अंदर वी डिडंट नो द मैकेनिज्म. Basically these kind of valves, what you are afraid of, once you post dilate, you are even other ones, once you post dilate, I think मैं काफ़ी आगे चला जाऊँगा इसमें, लेकिन once you post dilate you are always afraid of aortic regurgitation. So even मैं चले एक जुमला कहता हूँ, मैं ज़्यादा नहीं जाऊँगा क्योंकि मेरे अब वाकई भी दोबारा भी ये वर्कशॉप एक दफ़ा होनी है, डॉक्टर उस्मान ने करनी है, इसलिए मुझे अपने टाइम पे इसको कंप्लीट करना है, फिर आपने हैंड्स ऑन करने हैं और बहुत सारी चीज़ें हैं. तो इसलिए लेकिन आपके सवाल का जवाब एक मुख्तसर सा मैं दूँ कि आप इससे अंदाज़ा करें, व्हेन एवर अ यंग पेशेंट 30 साल का आदमी आ गया, वो कहता है कि जी 20% EF है, ये 40 साल का आदमी आ गया 20% EF है, सिवियर AS है, सर्जन ने मना कर दिया, आप इसका क्या करें? तावी नहीं करते. तो व्हाट दे से यू जस्ट बलून डायलेटेड, आपके ग्रेडियंट्स रिजॉल्व होंगे, द LV मे इम्प्रूव एंड आफ्टर 3 months सेंड हिम फॉर सर्जरी. बट इवन विद दिस बलून डायलेटेशन we need to keep a valve at the backup, because if this patient crashes after balloon dilatation and develops severe AR, in order to rescue you should have a valve at the back. तो ये जो आपका सवाल है कि इसको बलून डायलेट करें, बाकी चीज़ें करें, एट दैट टाइम वी डिडंट नो कि व्हाट इज़ द मैकेनिज्म, व्हाट्स हैपनिंग, वी रियली डिडंट नो. ऑन CT डिडंट शो एनीथिंग लाइक क्लियर कोई थ्रोम्बस ऐसी चीज़ें. द ओनली थिंग विच वी वर हैविंग इज सिवियर ग्रेडियंट्स, एंड वी एट दैट टाइम वी डिडंट नो व्हाट इज़ द मैकेनिज्म. Then later on, world studies and those post-mortem studies, they found out that they have got this thrombus. Please.
Sir, is there any data for asymptomatic severe AS patient and for that patient being considered for TAVI?
I told you before that the trial is going on. The trial is going on. I just told you that they have started. This is called early TAVI trial,
Sir.
And they are planning to enroll more than 1,000 patients. But when the trial comes out, I'm saying that they are pushing things towards it.
And my second question is, when the valve is being deployed, is there any space left out for the left vein being engaged with the catheter? Is there any space inside
Yes,
it?
definitely in these, I think I let me finish this one and then we can discuss.
Okay, sir.
Okay. Because I think that you are right, your all questions are valid, but the workshop is basically focusing on steps. So we have discussed this one, so I want you to focus on that practical things and then come up on this point. And I'll be answering those questions all inshallah. So femoral perforation, as I told you, most common complications are peripheral and most commonly, so femoral perforation, and we try to compress and every other thing, but when it doesn't work, finally a covered stent is the solution. Usually at femoral area, you don't want to put stents, but to save life, you have to do anything. But important thing is, मैं एक बात इसको शुरू में शायद मुझे कहना चाहिए था. If you are doing a TAVI and you don't have cover stents in your rack, all sizes, it's haram. It's haram to do TAVI. दुनिया के जो एक्सपर्ट तरीन लोग हैं, इसमें दो चीज़ें आपके लिए फ़र्ज़ हैं तावी करने में. नंबर वन, you should have all sizes of cover stent in your rack. Number two, don't work with a single valve. You should have a second valve at your rack. The valve, you may have any complication, you may need second valve at any time. So never be overconfident. वो कंपनी वाला कहेगा मैं एक वाल्व ले आया हूँ सर, आपके साइज़ का मौजूद है. आप कहेंगे नहीं मुझे दो चाहिए. क्या मरीज़ तो एक है, नहीं मुझे चाहिए दो वाल्व. एंड उसमें दुनिया के जो हम लोगों ने जो एक्सपर्ट तरीन लोग के साथ में वो वर्किंग, दे यूज टू कैंसिल द होल वर्कशॉप. फर्स्ट शो मी द ऑल कवर्ड स्टेंट्स. शो मी, ब्रिंग इट, लाओ यहाँ रखो सामने, फिर बात करेंगे आगे. ओके, सो बिकॉज you see this one, and next thing is ठीक है, most commonly this is a bend area when you try to negotiate. These are old age people, calcified vessel, fibrotics. Most commonly it perforate here, and the solution again, your safety wire is there. Solution again is a covered stent. Covered stent finally. And then I call it a chul in Urdu because I told my seniors, please stop. Okay, अब तो फट गए, छोड़ दें, बाद में कर लेंगे कि नहीं. So they decided to go through it and complete the procedure. So we had perforation in the beginning of the procedure, but they decided, okay, नहीं जी आज तो करना ही है, patient तो table पे है. So we went through this perforated covered stent and then we completed our procedure. So this can be done at the same time, but you need to have some chul. Okay. Next, the valve may slip down. Again, this is not common nowadays. This is mostly past because you can retrieve the valve, but previously with the core valve, once it is deployed, it starts slipping. You can pull it, you can force it, but if it is already gone into the LVOT, and it's causing AR, you don't have any other option. The valve is then, you go and put another valve at the right position, and usually it do well. The only thing I told you before, the chances of complete blocks are high. LV perforation. We had one incidence and we changed our practice. That's what I was telling you in the before. We didn't have this dedicated confida wire in the beginning. We used to make a shape of this Amplarger super stiff wire, and we know that Amplarger super stiff wire has got only soft portion of 4 centimeters. So when you try to make the shift, even you practically make, but the soft and the hard junction, the transaction is very short segment. So when you are pushing the system, the hard segment can straightly push and perforate the LV, and we lost the patient. Sorry. Yes, we try to because in order at this point of time we need to identify from where the perforation is, then cross, and then bring the device in. We didn't get enough time because patient has got severe AS with LV dysfunction with so many comorbidities. So this patient didn't give us enough time to think and go for it. और दोबारा कभी हमने किया नहीं, अभी आइंदा कभी.
It more halal.
Sorry?
Would you like to, in order to make it more halal, would you like to have a closer device available with you?
Yes, that can be done, but I think that the easier way was that we stopped using superadhesive implanter wire and we started using dedicated confida wire, which is you prevent complication as not you do complication and then manage it. But I think I agree with you that we should be able to and we should be ready for perforation and device closure if it happens. But ideally, the complications should be prevented before it happens. So in this one, we changed our practice and we started using dedicated confida wire for it, which has got the large floppy portion, and after that one we didn't have any perforation after this. Similarly, in order to prevent RB perforation, we started using balloon tip 5 French catheters so that the chances of having it will deflect with the flow. If it is forced forward, it will not tend to penetrate into the tissue. And it's 5 French, a softer one. So we changed our practice. Similarly, we had one case of nose cone trap. The valve didn't open and the nose cone, we were not able to bring the delivery system out. Valve पूरा खुला नहीं और वो जो इसका delivery system की जो nose cone है, it's still inside LV. Now you cannot leave it like this, and if you pull it out, it will, जैसे वो पेप्सी का ढकना खुलता है ये फिर करके निकाल के बाहर ले आएगा. अभी एक दिखाएंगे आपको. तो it can bring it out. So we decided to took another pigtail catheter, and with this pigtail catheter we pushed the nose cone and the delivery system down and make this space. वो तो जिस जगह से फंसा हुआ था उसको कोएक्सियल से हटाया तो nose cone came out. But you never try to force this one because it can pull the valve back. So this thing can also happen. Antegrade crossing. In one of the cases, thanks to our PTMC skills, Dr. Tahir Saghi did this case that we were not able to cross antegrade. The valve opening was so narrow, the opening was eccentric. So they decided to puncture like PTMC, go into LA. From LA to back into ascending aorta. Your sheet, this Mullen sheet is in LV. Your Berman angiographic catheter is going back into the ascending aorta. So we brought this one and we pushed the wire out into the descending aorta and snared that wire.
Have you tried from the apical approach if this was not possible, retrograde?
Apical approach, basically it needs a lot of surgical skills because you need to have hybrid lab because this is something more of surgical. And we are planning to do it, but nowadays, up till now, we are not doing it because of the non-availability of the hybrid lab and the surgical skills. But these things require extra surgical skills because they need to do cut down, open the chest, although minimally, but that needs stitching and need complete re-sterilization. So they think that this is something not fit to be done in the routine lab. People may be doing it, but usually it requires extra training skills and everything, and we are planning to do it, but nowadays we are not doing it. So we snared the valve. This was to us comparatively a simpler thing. So I snared the valve, and on this valve we loaded the again multi-purpose, and then it was easier. Valve पे system ले जाके pigtail catheter, now it's going antegradely into LV, and on this wire then we perform the TAVI procedure. I think probably the last slide of mine. You need to see this one very carefully. Balloon inflated. Just last 1 second, what happens? Okay, what happened? The person who was doing rapid pacing, होना ये चाहिए हमेशा कि पहले रैपिड पेसिंग ऑन होगी, प्रेशर ड्रॉप हो गए, आपने बलून इन्फ्लेट किया, फिर पहले बलून डिफ्लेट होगा, फिर रैपिड पेसिंग ऑफ होगी. That's what I was telling you. The rapid pacing person offed rapid pacing as soon even the balloon was inflated. तो बलून ने वाल्व को पकड़ा हुआ था, रैपिड पेसिंग ऑफ हुई, एलवी ने अपने पूरे नॉर्मल 120 के प्रेशर से ढप करके बलून को, और बलून आपका वाल्व भी लेके बाहर आ गया. तो इसलिए दिस इज द सीक्वेंस इज इम्पॉर्टेंट, द टीम वर्क इज इम्पॉर्टेंट. द मैसेज इज द TAVI इज अ टीम वर्क. It's not the thing that a single person is doing. Your anesthetist, your echo, your CT, your second operator, मेरे जैसा कोई होएगा वो तो आप उस पर एक नज़र इधर रखें और एक इधर रखें. तो इसलिए I think
excuse me, do you use the transesophageal echo while
so the valve called up, and then you have to put another valve. So in previous days when we were not able to, this is probably the last slide, in previous days when the core valve was there, and sometimes the core valve was also retrieved, but in this way that it could not be retrieved back into the sheet, but you pull it back and then you bring down into this descending aorta in the open form, and you bring it inside the 18 French sheet. This was done with the core valve, and then you reload it and do it again. But this was vigorous maneuvers, but nowadays you don't need to learn these things because the equipment has changed, that the life has become easier. Okay, I think we stop right now, and I will request you to divide into 2 groups. And one group will go at the back, one group will stay here at the back. Sir, आप उधर इधर. Dr. Tahir Sagir, Dr. Osman, are you with us? Dr. Osman, are you with us? So अगर आप यहाँ आ जाएं. So Dr. Osman will do the hands-on here, and Dr. Tahir Sagir will go at the back and will tell you the hardware there. So we have got original valve, the delivery system at the back, and so you divide into 2, and then we will shuffle. वहाँ पर आप ओरिजिनल वाल्व देख लें, उसको फील कर लें, उसका डिलीवरी सिस्टम कैसा होता है, क्या है, और यहाँ पर आप आके फिर वाल्व की प्रैक्टिस कर लें. एंड आई विल रिक्वेस्ट डॉक्टर ताहिर सगीर प्लीज़, अगर हम इसको ऐसा
है इतनी
Thank you.